My name is Bill Cobb. It's nice to meet everyone. It's a little strange, I guess, to talk under this setting with virtual, but I hope everyone is able to see the presentation. And please, if you have any questions, I'm happy to answer them at any time. So what I've been asked to talk about today is back issues and some surgical possibilities for patients with back pain or neurological symptoms. And I entitled it Senior Edition because I think the audience is mostly seniors, and that is a little bit different in terms of how we address certain problems with the back. So again, if there's any issues, please let us know so we can get it corrected, and we'll get started, okay? So there's a couple facts I just wanted to talk about in the United States because of the baby boomers, which are now all getting to be in the 65 and older age. There's been a big increase in the number of senior citizens in this country. So in 2010, which is only 10 years ago, there were 36 million people who were greater than 65 years old. And if you look at this graph over here on the side, this green line, these are the adults over the age of 65. And this orange line is children under the age of 18. And you can see that there was a significantly more younger people than older people at that time, just even 4 years ago. This is in 2016. And just based on the way the population is changing in 2020, which is now, there's over 50 million seniors, 14 million more than only 10 years ago. And in 2030, there's predicted to be over 70 million seniors in this country. And if you look at the graph, at about the year 2034, there will be equal number of senior citizens and minors. And then once you get way past into 2060, there are more seniors than children, and that number is approaching 100 million. So, why does this matter? In terms of a back pain or a spine point of view, as we age, so do our spines. Unfortunately, I try to talk to patients. They ask, "Oh, why is my back hurt? Or why am I having problems with my back?" And it just, unfortunately, it comes with as we age. It's kind of like getting gray hair. As we age, so do our spines, and more problems develop over time. And this can be a significant public health concern in the United States with patients with spinal conditions. It can lead to a lot of disability, a lot of morbidity, a lot of problems for patients. There's the functional and psychosocial impairment of not being able to get around the same way if there's a lot of back pain and people can't do things that they want to do or that they were doing before. Patients can even have difficulty performing their activities of daily living, getting meals, getting up and down to the bathroom. It can affect sleep. Patients will often say they can't sleep through the night because there's pain. This can lead to worsening depression, and in the senior citizen population, depression is a serious mental health issue. And any other health issues, patients with other medical problems, these are often exacerbated by the lack of activity and lack of pain. So it's something that needs to be really considered seriously. In terms of the spine itself, even in patients over 50 years and older, which I'm approaching pretty rapidly, 90% of patients, if you looked at their MRI, have evidence of degenerative spine disease. So that's a pretty significant number of people at age 50. 9 out of 10 have degenerative spine disease. Some studies suggest that up to 75% of seniors live with some level of back pain. Again, that's 3 out of 4 people have back pain or lower extremity symptoms. And spinal stenosis, which is an entity that we'll discuss in greater detail, can occur in up to 10% of seniors, and that can be very, very debilitating. But luckily, good treatments are available. So just really quickly, there's kind of 4 areas that we'll get through today. So what is neurosurgical spine? Everyone always asks me, "Oh, I didn't know that neurosurgeons do spine. I thought orthopedic doctors do spine." So I'll just do a brief slide on that, and then we'll spend some time just to discuss lumbar pathology or low back issues. So low back pain or lumbar stenosis. I also wanted to talk about cervical pathology because, again, as we age, those can be serious issues with both cervical radiculopathy or cervical myelopathy, which I'll explain a little bit better as we go along. And then fractures, which again also occur in an older population. So we'll talk about that as well. So neurosurgery spine, as a neurosurgeon, our residency is 7 years long, and more than half of that is spent on operating or treating patients with spine issues, mostly because the spine, not only are there bones that are there, but the spinal cord and nerves are very intimate or implicit in the treatment of the spine. So degenerative spine disease, which is most of the topic of this particular talk, and trauma, spine tumors, infections, deformity, those are all things that any neurosurgeon who's graduated from a residency would be well versed in taking care of. And really the philosophy for degenerative spine disease, at least, is to basically decompress neural elements such as the nerves of the spinal cord to relieve any symptoms. So as neurosurgeons, we're quite comfortable working in and around the spinal cord and spinal nerves, and to stabilize the spine if necessary. So that's sort of our role in taking care of spine disease. Just a quick anatomy lesson. So if we look over here on the left, can they see my pointer? Can you see that? They can't see the pointer. Okay. So if you look on the left, it shows the cervical spine. So that's the neck. That's made out of 7 bones. The thoracic spine, which is the mid-back. We're not going to talk a lot about that today, but that has 12 bones. And the lumbar spine is made up of 5 bones. Those are the 3 main parts of the mobile spine. And then the sacrum and coccyx also, but that's really considered more to be part of the pelvis. Each of the bones, whether you're in the neck, the mid-back, or the low back, has an anterior part, which is called the vertebral body. So if you look at it from the side, this is the vertebral body right here on the left. And then behind it, this opening here is where the spinal cord or the nerve roots would be traveling. If you talk about the lumbar spine in particular, the lumbar spine is a little bit different than the cervical spine because the spinal cord stops above that level. So it's really just the nerve roots that you're dealing with. So it's a little bit easier to take care of down there. But this image is to show you that this is the vertebral body in the front. This is the disc. If you've ever heard of a herniated disc, this is what we're talking about. And the bone above and the bone below create this opening called the foramen, and that's where the nerve comes out. And you can see that that's not a very large opening. So any problems with the bones or the disc or any of the surrounding structures can affect the nerves. And that's really what we do as neurosurgeons to help take care of that. So let's talk about low back pathology. And I sort of broke it down into 2 main types. You know, there are many, many more, but this is especially for seniors or patients who are into their 60s and 70s, even patients in their 50s. These are really the 2 classic issues that most people deal with. One is classic low back pain, you know, usually worse in the morning, a lot of pain across the back, can be very, very debilitating. And then the other one is this entity that's called sciatica. It's not a great term, but basically that's pain that goes not necessarily in the center of the back, but goes down through the buttocks and down the leg, and can be very, very severe and very debilitating as well. So just to talk about back pain, there's a little slide here I stole from the internet that shows all the different causes of back pain, and there are many. Luckily for most people will usually get a flare-up of back pain. Someone's out raking leaves or doing a lot of walking. They wake up the next day with a lot of low back pain, and usually over the course of the next couple days to couple weeks, that pain will get better on its own. So the most common cause of low back pain is either muscle or ligament pain, meaning that maybe you overdid it, pulled a muscle, strained a ligament, and that causes low back pain. Again, that will usually get better on its own. There's bony pain. As we age, the bones tend to get very mottled. A lot of patients have osteopenia or osteoporosis, so the bones are not nearly as strong as they were once when we were, 20 or 25 years old. So there can be bone pain. A lot of chronic back pain is really arthritis. When we think of arthritis, usually we're talking about a single joint like a knee, but in the back, I mentioned to you that there's over 30 different bones, and each of them connect in 2 different places. So there's a lot of different places where back pain can exist. So arthritic or joint pain, discogenic pain, the discs themselves begin to break down. The problem with the disc is that the disc is like a shock absorber in your car. And if any of you have had a car for a long time, you know that the shocks don't last forever. When we were designed, we weren't really designed to live as long as we do. So even patients in their 30s and 40s will show evidence of breakdown of the discs. And as the discs start to break down, they begin to collapse, and that can cause a lot of pain. And then finally, the last, and thankfully the least common for back pain, is nerve pain. So if you have a pinched nerve, or if the nerve is being compressed, that can also manifest itself as back pain. The overwhelming treatment goal for this is non-surgical, for just classic back pain. It tends to have very, very poor results with surgery. Surgeries for back pain usually are quite big procedures that require fusing the bones together, and that oftentimes can lead to more problems than it helps. So the frontline treatments are medications, Tylenol, ibuprofen. There are other types of medicines that patients can sometimes get, tramadol. There's physical therapy that can be done to try to help with back pain, chiropractic manipulation, acupuncture. There are all different types of treatments. There are lots of commercials on TV about back pain. Oftentimes, seeing a pain management doctor or a physical rehabilitation doctor can also be helpful to try to create a program that can help you with the back pain. And again, I would stress that for isolated back pain, surgery is really for when all other options have been exhausted, because again, the results of surgery in general are quite poor. So let's talk about lumbar stenosis, which is the second entity, which is much, much different and actually tends to respond to surgical treatment very, very well. So anytime you talk about stenosis in the body, that's something that results in narrowing of a normal space. So lumbar stenosis is narrowing of the spinal canal. So if you look at this picture over here on the right, this is an MRI. And this is looking at the spine from the side. So a typical presentation of a patient might be a 63-year-old gentleman, usually very active, but over the past several months has been noting that as he gets up to walk, he starts getting pain into both buttocks area. Occasionally he'll go down the leg, maybe the left leg, maybe the right leg. There's some good days, there's some bad days, but over the course of the past several months, it's really been kind of getting worse and worse. To the point where it can only walk a couple of blocks before you have to take a rest. And that's kind of a classic presentation. So if we look at this image, this is a cross section. So if we made a cross section through here, just like that, we would be looking at it. So if the belly was up here and the back was laying down on the table like this is that vertebral body and disc in the front. This is the joint on the right side and the left side. And in here, these are the nerve roots floating in spinal fluid, which is that bright signal. So you can see the individual nerve roots here. But if I bring you down to this slide, you can see that you can't even see the spinal canal at all, because the joints themselves are so overgrown that they're growing into the spinal canal and completely compressing those nerves, and that manifests itself as those pain. I mentioned when I talked about that presentation that there's something called neurogenic claudication. And that classically is lower extremity pain with activity, usually into the buttocks or the side of the back and down the leg classically. Can also manifest itself as back pain, can also cause numbness in the legs. And this typically is worse with walking or standing, tends to get better with rest. I put this thing here, the shopping cart sign, because many people will say that if they go shopping, they'll lean over on the shopping cart as they walk, and it tends to make them feel a lot better because just mechanically, as you do that, when you bend forward, it tends to create a little bit more room in the spinal canal and feels a little bit better. So that's the most common cause is basically just wear and tear and degenerative changes in the spine, but it can also be caused by a disc herniation, something called spondylolisthesis, where there's the bones are not lined up correctly, which narrows the canal, or degenerative scoliosis, where the architecture, the way that the spine falls is no longer in its optimal way, and it also causes stenosis. So really, you can try to treat spinal stenosis conservatively, and we'll talk about that, but really the best treatment is surgery. But we should discuss some of the pitfalls of surgery in the elderly. Most patients who are into their 60s and 70s have some other medical conditions, whether it's high blood pressure, high cholesterol, atrial fibrillation, lung disease, kidney disease. So to put someone through surgery, all these things have to be considered. Many patients also, unfortunately, as we age, we get onto more and more medications. Some of them are antiplatelet or anticoagulation, like aspirin or Plavix or Coumadin or Eliquis. Unfortunately, we can't operate with those medications because they can cause a lot of bleeding. So there is a small amount of risk to stop those medications for a short amount of time before surgery and after surgery. Older patients tend to require a longer hospital stay. One of the reasons is that the medications that you get for surgery, our kidneys and liver age too. They don't break down those medications quite as well as they did, decades before. So sometimes it takes a little bit longer to get up and going. And because of that, the post-op complications can also be more apparent and more severe. So there's less activity. It's harder to breathe, so that can lead to pneumonia. Less activity can lead to deep vein thrombosis or clotting in the legs. Oftentimes, patients require more help, home nurse, rehab to do their activities of daily living. The medications tend to cause constipation in anyone, but as we age, it tends to be a bigger problem, and overall decreased activity that leads to poorer recovery. Having said that, to talk about the treatment for lumbar stenosis, I mentioned there are some non-operative possibilities. So there are medications, the NSAIDs like ibuprofen. There are also acetaminophen like Tylenol. I put an asterisk next to the opioids because a big study came out a couple years ago to suggest that opioids for back pain, the risk far outweighed any benefit. So if you're having a lot of back pain and you're taking Percocet or Vicodin, that's the time to really make sure you're seeing some other doctors to try and see if there are some better options than what you're doing currently. Physical therapy is really to try to work on flexibility and strengthening of the core muscles to try to take some stress off the back and help with that. And then a pain management physician can do some manipulations where they do injections. So there's two main types of injections. So an epidural steroid injection or an ESI, what they would do is they would take a needle and try to inject it right next to the spine. The steroids are very potent anti-inflammatory and try to get that medication to run into where the nerves are to try to take away some of the inflammation and pain. And facet ablations, sometimes if patients have back pain, there's a little tiny nerve that innervates the joint. And what they can do is they can do an injection with Novocaine, basically, which is a numbing medicine. And if the back pain or the leg pain gets better, they can go in with a heated filament and kind of burn that little nerve to try to help with the pain, which can be quite effective. But really the mainstay for stenosis, again, another study about 5 to 10 years ago came out that really suggested that although non-operative treatments can be helpful for classic lumbar stenosis, really the optimal treatment is an operation. And really the goal of that operation is, if you look at the normal spinal canal where you can see the nerves, is to decompress this area and basically shave out all of this thickened tissue to recreate this space for the nerves. And once the nerves are decompressed, patients will get better rather quickly. So that's really the goal. And there's two ways to do that. One is a minimally invasive decompression, and the other is a big decompression and fusion. And those are both good procedures, but they both have their benefits and they both have their pitfalls as well. So to talk about a minimally invasive lumbar decompression, this is a small incision. It's about the size of a dime. It's about 18 millimeters. It's a same-day procedure, meaning that most patients can come in and go home the same day, and it's about 90% effective. So it may be a little bit difficult to understand this drawing here, but this is as if you were laying face down on a table. So up here, this is your backside facing up, and the surgeon has made a small incision in the skin and dropped this tubular retractor down right onto what's called the lamina bone. And then we use a microscope to look through and operate through this tube, and could do a laminectomy, meaning remove this bone completely, which would completely decompress the nerves. If there was a herniated disc, as in this photo, could reach and remove that herniated disc. And again, the idea would be to turn this level of stenosis by shaving away all of this tissue to make it look like this again. That can be done for classic laminectomy or something called a microdiscectomy, or even one-sided to just do what's called a laminotomy. It's a great procedure. It takes about an hour, hour and a half. More than one level can be done. You can do one level, you can do 2 levels, you can do 3 levels. It's a very effective procedure. Now for a lumbar fusion, that's a much bigger procedure. It's a good procedure, but the recovery is a lot longer. So again, if you look at this photo here, this is looking from the side. These are the nerve roots that are coming down. This bright signal is the spinal fluid. As we get to this level, which is between the 3rd and 4th bone, you can see that there's some stenosis there. And between the 4th and 5th bone, again, it looks like there's some crowding there as well. So there's 2 levels. Maybe a little bit hard to see on this x-ray, but the bones are not aligned perfectly. If you look here, they're aligned up here, but it's kind of slid forward. So there's not perfect alignment. And then if we look at this picture here, at the joint, there's a lot of inflammation in the joint itself, and it's a little bit unstable. So this person probably would be better candidate for a fusion. And this offers a much bigger decompression. You take out the entire disc here, so you completely remove all of this, all in the front, but it does require instrumentation because you've now further destabilized the spine. It can be done minimally invasive nowadays. So again, this is our tube here, where you can do all the instrumentation through the tube. But the classic is that once you have these bones exposed, you're going to put a screw from the back to the front at both levels in order to hold everything securely. And this is what these constructs can look like. So this is looking from the front. There's one on one side and one on the other. And there's one at the top level and one at the bottom level for a total of 4 screws. And these little lines in here, that's what's called the interbody graft, which is a plastic spacer that's placed in between the 2 bones so that it fuses together in the front and fuses together in the back, and the instrumentation holds it in place while that fusion occurs. So again, it's a good procedure. It takes a little bit longer. It can be 3 hours, 4 hours. But the complications and the failure rates are higher. So for instance, our goal is to get the bones to fuse together so it's nice and stable. Sometimes they don't fuse for whatever reason, and patients need to have another operation done to try to fix that. And patients, instead of a same-day procedure, often are in the hospital 2 or 3, sometimes 4 days, because the pain is usually much more significant for this operation than the other. So that pretty much takes care of any lumbar pathology. So I wanted to just talk briefly about the neck. I don't know, is it a good time to maybe ask any questions, or will we wait till the end?
There's 4 questions.
Okay, yeah. Why don't we ask that? Can I hear them or no?
Yeah, I can read it.
Okay.
So the first one says, can you alert listeners to the importance of radiologists and neurosurgeons carefully reviewing MRIs before disc surgery to detect a conjoined nerve root at the level of the disc herniation?
Sure.
As you know, to operate without appreciating a conjoined nerve root risks tearing the nerve.
Sure. So someone asked, that's a highly advanced question, but someone asked about a conjoined nerve root. So I'd be lying if I said I knew what the incidence of a conjoined nerve root is, but it's not all that common. But if we look at this picture, which I hope you can see, at each level between the bone above and bone below, there's that level called the foramen. And you can see that one nerve comes out of it. And then at the next level down, one nerve comes out. And at the next level down, another nerve comes out. So a conjoined nerve would be that, for whatever reason, anatomically, there's always slight variations with every person, that 2 of these nerves are hooked up together and they come out through the same foramen. So as you operate from this angle, sometimes the anatomy is a little bit different. So yes, it would be important for the radiologist or for the surgeon to see that, but sometimes it can be quite difficult, especially because it's very, very uncommon. And sometimes you could be surprised as you operate, and you could get into a situation where you get to see you see the nerve in a place where you weren't expecting, and that can definitely cause an injury. So yes, I would agree. It would be important to know that beforehand. Sometimes it happens intraoperatively where you see it, and it can be a little bit more difficult. Sometimes the surgeon would have to abort the procedure and then talk to the patient about doing a different procedure. But thankfully, it doesn't often result in an injury too often. I hope that answers the question. Yeah.
Does the thickened tissue, which is removed for spinal stenosis, thicken after time, and is surgery required again?
So that's a great question. So someone asked for lumbar stenosis. I'm showing you this thickened tissue here. This is part of the ligament and the joint. Asked that if it happened once, essentially, where it thickened and grew, could it happen again? Yes, it can. I would say the vast majority of people who have surgery for lumbar stenosis only require one surgery, but it is always possible, and I do caution patients that it's possible that at the same level or a different level, patients may require a second procedure. Usually that takes a long time, several years, but it is possible that you could clean all this out, and then over time you can get scar tissue or granulation tissue that could result in the necessity for another procedure. All right. Okay.
What is the long-term effect having both of these surgeries?
So the long-term effect, that's another great question for both of these surgeries. So for the minimally invasive lumbar decompression, there's very, very few long-term effects because we're really only removing a little bit of this bone, and architecturally it doesn't really have that much of an effect. For a fusion, that can definitely have long-term effects. So basically what you've done now, when you fuse one level, you're eliminating motion at that level, and that puts more pressure above and below the construct. So whether it's a year or 5 years or 10 years or never, it is possible that you'll get accelerated disease at an adjacent level. It has a term, adjacent level disease, that may need to be addressed further down the line. So the minimally invasive one has very few long-term effects, but a fusion can definitely have long-term effects.
Okay. Next question. About 15% on autopsy is the incidence of conjoined nerve roots.
Got it. Okay.
And then we have, is spinal stenosis genetically passed down?
That's a great question. There's never been, the question was, is spinal stenosis genetically passed along? So it's a hard question. I would say most likely there's some element of it. We kind of look like our parents, so it would make sense that the spines are probably similar as well. There's never really been a study that I know of that really studied that. And then the biggest issue really is that it's so common and it happens to so many people, it would really be hard to find a true genetic component. But, it is quite possible if you have a parent who had spinal stenosis that you could run into that problem as well. All right. All right. So that was the questions for lumbar. Thank you for the questions. If you have any other ones, we can answer them again at the end. I wanted to discuss the neck as well. It's not the low back, but neck pathology can be a very serious problem for patients as we get older also. And again, there's really two main types of neck pathology. One is neck pain or radiculopathy, which is really pain down the arm, or myelopathy, which can be a very serious problem that requires urgent intervention. So again, just looking at the spine anatomy, now we're talking about the neck. And really the big difference between the lumbar spine and the cervical spine is that in the neck, the spinal cord is still present. So whereas in the lumbar spine, it's just the nerve roots, the nerve roots can really take much more of a beating than the spinal cord. So really in the lumbar spine, unless you're having symptoms, even if you have stenosis, we don't really need to do anything. Whereas in the cervical spine, if you have spinal cord compression, that becomes a much more urgent matter. So just to discuss cervical radiculopathy, that often happens with a disc herniation or disc collapse. Can be associated with degenerative joint disease also, or ligaments hypertrophy, all these things that crowd the spinal cord or the nerve. If you look at this MRI, this is looking at the neck from the side. So this is the brain and the spinal cord as it comes down the spinal column. And you can see there's this big disc herniation. And if you look over here on the other side, this is that disc herniation pressing on the edge of the spinal cord and where the nerve root is. And it kind of has a very classic presentation of symptoms where if it's at the C4-5 level, there's pain into the deltoid muscle. If you have it at the C5-6 level, it'll go all the way down into the hand and into these two fingers, kind of like a six-shooter. If it's between C6 and C7, it tends to be the middle three fingers that cause the issues. And if it's between C7 and T1, it tends to be the pinky finger. So because there's compression of the nerve roots, it often presents as pain. And sometimes you get numbness in that area, but you won't have the same symptoms that you would get from spinal cord compression. Again, the treatments to that are very similar to lumbar stenosis, non-operative with medications, Tylenol, ibuprofen, physical therapy, again, to try to get flexibility and strengthening. Pain managers can also do injections at this level too. And really the biggest reason is that for most patients with just nerve pain, that will get better over time. So we try to give it a little bit of time before we have to do any operation. But again, the operations are similar. There's basically a choice for just a posterior decompression or foraminotomy without having to do any instrumentation. And basically what's done for that is that we would go in and do the same thing where we do that laminectomy and identify the nerve root and just make sure it's no longer being pinched. And again, those symptoms will usually go away pretty quickly. The other option is that in the neck, you have the option for an anterior approach. So an incision is made in the neck, and the fibers and the muscles of the neck are kind of just moved out of the way, and we get right to the front of the spine and take out that entire disc, put a little plastic spacer then and cover it with a plate and some screws. It's a great operation. It's very successful. It allows for a very, very big decompression. The pain usually goes away pretty quickly. The big problem in older adults is that as we age, our swallowing tends to get worse. So someone who's 70-year-old versus someone who's 30 years old, swallowing issues, if you're tested, often are present that you don't even really realize as we get older. So by doing that anterior approach with manipulation of the neck, some of those swallowing issues can worsen significantly and maybe even be permanent. So unless absolutely necessary, oftentimes a lot of surgeons will decide to do the posterior approach to avoid any of those complications. So cervical radiculopathy or arm pain can be a problem for older adults, but not as much as classic cervical stenosis or cervical myelopathy is the term, and that's spinal cord compression. And this is kind of an insidious presentation. So this would be classically someone who's maybe 70 years old, a 70-year-old woman who has been in her normal state of health, has high blood pressure, high cholesterol, borderline diabetes, but overall healthy and active. And over the course of the past 6 to 7 months has been noting clumsiness in the hands, basically having a hard time getting dressed and zipping a coat, and also notes less balance, steadiness, more issues with balance and walking. Can't really put her finger on it, but just knows that versus Thanksgiving of last year was doing everything fine, and now it's summertime and just not really able to walk because of the balance issue. So this is often due to compression of the spinal cord and is fairly prevalent in the older population. Again, it's due to degenerative spine disease as the discs collapse or disc herniation, the joints as they get bigger because of degenerative changes. If you look at this MRI, again, this is looking at the neck from the side. This is the brain, and this is the spinal cord as it comes down. These are the bones in the front. This is the ring and the bones in the back of the neck. And as you see, there are the bright signal is spinal fluid. So behind the second bone, it looks okay. But once you start getting down here to the fifth and sixth bones, you see these big disc bulges pushing into the spinal cord. I'm sure you won't be able to see it, but if you were looking at the MRI itself, there's some bright signal in the spinal cord itself, which is something called myomalacia, which is swelling in the spinal cord. And that becomes much more of an urgent process. And really the treatment for that is surgical. If there's a lot of health issues, you can try to treat it with physical therapy, but really the goal is to decompress the spinal cord. And there's two main ways to do that. One is called a laminoplasty. And this figure on the top here is a drawing that I stole also from the internet about decompressing with a laminoplasty. So this yellow circle here looks like the sun is basically the spinal cord. And you can see it's being compressed from the front and the back. And what's done for the laminoplasty is 2 cuts with a drill are made. So there's a cut on one side all the way through and halfway through on the other. And then basically it's open like a gate like that. And you can see as you swing this open, it creates more room around the spinal cord. So it's no longer being compressed. And then you take one of these little plates and you stick it on the open side to hold it open. And now instead of having this tight canal, you've opened this up with the laminoplasty so that there's plenty of room. And you can do that at 1 level, you can do it at 2 levels, you can do it at 5 levels. It's a fast procedure. It's not a fusion, so you have full motion of the neck. And it's actually did one this morning before this talk. So it can be a very, very effective procedure to decompress the spinal cord. The other possibility is a laminectomy and fusion. That's a little bit more aggressive. It enables you to fully decompress by, instead of opening it this way, you just remove this whole piece so that now there's nothing in the back so that the spinal cord can float away from the front of the spinal canal. Not absolutely necessary, but often this is backed up with instrumentation. So screws are placed into each bone and then a rod is placed in to hold it in place. So this is looking from the front. So you can see the screws on one side and the other, and then a rod going through each one. And then this is looking from the side. Again, you can see the screws going to the bones, and then the rod holds it in place. That can definitely reduce motion. Often the motion that's left is functional, but it can have some effect on motion of the neck. That's usually saved if there's not only stenosis, but some element of spinal instability. And then in terms of the recovery, I try to caution patients, we don't know what kind of recovery we will get. The primary goal always is to make sure things don't get worse. So sometimes patients, they've been walking with a walker for the past month or two. We want to make sure that they don't progress to have to use a wheelchair and not be able to use the arms or legs at all. So with surgery, once we've decompressed the spinal cord, our goal is to make sure that everything stays the same, doesn't get worse. Having said that, most patients will get significant recovery. It's rare to get 100% recovery, but most patients will get some meaningful recovery, meaning that if it got so bad that they needed a walker or a cane, most patients with physical therapy will get back to the point where they can walk unassisted. And really the most important thing after surgery is physical therapy, because the spinal cord, because of all the swelling, was not functioning properly. And patients lose the ability to walk or use their hands. And again, physical therapy can really help with that over time. All right, so does anybody have any questions about the neck before we kind of finish up? Okay, good. All right, I just wanted to spend the last few minutes talking about fractures. In terms of the spine, there's many, many different types of fractures. One of the biggest issues is whether or not the spine is stable or unstable. And okay, sorry, let me answer that one question first. Yeah.
Do the rods and screws have to be
do the rods and screws have to be replaced? Usually not. I would say 95% of the time not. The only time that they would have to be replaced would be 2. Number 1, if there was an additional issue above or below where the rods are, and if you had to add to it, or sometimes one of the big problems with the fusion is sometimes the bones don't fuse, and if they don't fuse, then the surgery oftentimes needs to be redone. But usually once that instrumentation is in there, it stays there forever. All right, that's okay. So anyway, getting back to the fractures, I put this word prevention in capital letters with a bunch of exclamation points because that's really the key. And part of the problem is that for many of us as we get older, in order to maintain individuality and be able to do things on our own, we oftentimes keep doing things as we used to do, which is fine, except that unfortunately, as we age, our balance just naturally gets a little bit worse, and the bones definitely are not as strong as they used to be. So fall precaution is really of the utmost importance. So I would stress to anyone, if you're having any issues with balance at all, make sure you see your doctor or physical therapist so they can work on making sure that we prevent any falls, so we can prevent any of these injuries. So there's really two common types of spinal fractures in elderly patients. One is a compression fracture, and then a certain cervical fracture called the dens fracture and odontoid fracture, and I'll go over those very, very briefly. So compression fracture, very, very common. It's associated with decreased bone strength. Unfortunately, as we age, the incidence of osteoporosis and osteopenia correlates with age. Again, unfortunately, it affects women more than men, particularly postmenopausal women. So up to 25% of postmenopausal women will have a compression fracture. Sometimes people don't even know it, but it's very, very common. As I mentioned before, it correlates with age. For women over the age of 80, it's up to 40%. So that's almost half of women over the age of 80 have compression fractures. The biggest issue is that for any individual with a compression fracture, there's a 15% higher mortality rate because of all the complications associated with it. And these complications, while it may seem insignificant at the time, during the healing process, which can take up to 12 weeks, there's a lot of pain, and that pain leads to inactivity, and inactivity leads to a lot of medical complications. There's loss of independence, increased nursing assistant need, and that certainly leads to mood problems and depression. The lack of movement can lead to deep vein thrombosis, which can also be a big health risk. Same thing, pneumonia, muscle wasting and weakness. So while the initial fracture does not seem as it may be a big deal, it certainly causes significant health concern over time. So what's the treatment? Thankfully, most treatments are really conservative. So basically, you have a weak bone that's kind of set up like this, and it kind of wedges forward and cracks. So as it compacts, it now becomes much more dense. So even though it doesn't look perfect, you can see it's kind of bent forward here. Eventually, that will heal in place and become quite strong. So, the back pain can last. Severe back pain can last 4 to 6 weeks, and you can even have discomfort 3, 4, 5 months later, but it should heal. So the first treatment is a brace, which is up here. I don't know if you've ever had to wear a brace or ever seen one. They are not comfortable at all, but that will keep the back nice and stable to allow things to heal. The second is something called a kyphoplasty or vertebroplasty. It's kind of a little image, and maybe hard to see on your screen, but basically what's done is that a needle is threaded through the bone from the back to the front, and a balloon is opened up in that space, and then cement is placed into that opening, and that will basically strengthen the bone. And that's quite good with helping with pain. And I would say rare cases, surgery is necessary. I don't know if you can see this picture very well, but I just wanted to show you the length of the constructs sometimes that are necessary to help hold everything together, because the bone quality is already poor. So for this particular construct, there's 4 levels of screws above. There's a kyphoplasty at the level of the fracture. They also had to put some cement into where the screw was going. So these are big, long surgeries that carry high morbidity, and really would like to avoid those at all costs. So that's for the compression fracture. And again, I put that prevention is key. So do whatever you can to avoid falling. There's so many risks of falling. Break a wrist, hit your head and get a head bleed, compression fractures, neck fractures. So I put that there. And then the second fracture, the last fracture I want to talk about, is something called a cervical odontoid or a dens fracture. So if you look at this, this is looking from the back. The skull would be resting right on top of the first cervical bone, C1. And then C2 is this strangely shaped bone that has this little peg on top of it. And that basically holds the head onto the spine, essentially. So it's a very important bone, and it's a very weak bone, even in young patients. because it's very, very stiff and there's very little compliance. So any force, particularly to the front of the head, so if somebody falls and hits their forehead on the countertop or hits their floor on the head or on the side of the couch, that whiplash injury can result in fracture of that odontoid, which is the piece of that bone of C2. And this is a very, very significant public health issue. I put this number here, $1.5 billion spent annually in this country to treat the odontoid fractures. And I can just tell you there are no great treatments for this fracture. In patients 65 and over, it's the most common cervical fracture. In patients 80 years and old, it's the most common overall fracture. There's a very, very high non-union rate, meaning that in 60 to 70% of patients, it never fully fuses together. And even with surgical fixation, it's a 33% non-union rate, so 1 out of 3. So it's very difficult to treat. And the 30-day mortality rate is very equal to a hip fracture, where there's 10 to 25% mortality rate at 30 days and a 20 to 50% mortality rate at 1 year. So again, I would stress that prevention is by far the best treatment for this fracture. The way that it's treated usually is with a cervical collar. I'm sure that everyone has seen a cervical collar. It's not comfortable and needs to be worn for a long time. It can lead to breakdown in the skin of the chin. It can cause breakdown of the skin in the back of the head. People hate it, and it really needs to be worn consistently for a good 10 to 12 weeks. And even with that, it's pretty rare to get a bony union, but usually there'll be a fibrous scar that forms that will hold it in place enough for it to be stable. So usually, as long as it's pretty well aligned and it's not frankly unstable, the treatment usually is a cervical collar. You can also use a halo. This was a little bit more prevalent 20 years ago, but this led to significant morbidity because it's very difficult to eat in a halo, and patients did very, very poorly. So it's almost never used in older patients at this point. There are surgeries, so there's something called the odontoid screw. So basically, a screw is placed through the bottom of the second cervical bone all the way up through the fracture and pulls it together. It's a great treatment, but just like the anterior approach for older patients for a disc issue, this carries a very, very high comorbidity of dysphagia, where it makes it very difficult for patients to swallow. So it's almost never used in older patients. So really the mainstay for surgery is a posterior approach where screws are placed in the back of C1, the back of C2, and then rods are placed to hold it in place. This person also had a laminoplasty. Those are the little plates I showed you about earlier. So that's basically the primary treatment for that. And again, I'll just stress again, for all the fractures, really prevention is key. So particularly in the wintertime, please be careful. And then really this is my last slide. We're getting towards the end anyway. I just wanted to point out some red flags for back pain. I already told you that up to 90% of people have some episode of back pain in their life at any age. So it's one of the most common reasons that patients go to the emergency room. And thankfully, the vast majority of these will get better on their own. So in most cases, we try to treat things conservatively and let the body heal itself. But there are certain situations where this should be taken quite seriously. So for instance, if someone has a cancer history, unexplained weight loss, that's a red flag where you should definitely seek medical attention. This is an MRI looking from the side in the lumbar spine, and you can see this is a normal bone, and then you have this darkened out piece here at L3, L2, and L1. Those are cancerous lesions for somebody who had lung cancer. That obviously is an urgent medical situation. Also, if there's back pain that's associated with fever or night sweats or history of drug abuse, that can lead to an infection, and that's what this picture is over here. If you look at the bones above, this is a normal bone and a normal disc, normal bone, normal disc. Now you see this is kind of chewed up bone. The disc is completely infected, as is the bone below. That's classic for discitis, osteomyelitis. Hopefully it can be treated with medications, but sometimes requires surgery for that as well. But that definitely requires medical attention. Anybody who's on long-term steroid use or is immunocompromised for whatever reason, that can cause osteoporosis. If you have osteoporosis at all with back pain, that should also be, you should seek care from a doctor as well. And then the most significant is their neurological symptoms. Severe weakness, incontinence, and back pain. Those are things that should be also addressed quickly with a doctor. So I think that's 1 minute before 3 o'clock. Thank you very much. Again, my name is Bill Cobb. I'm one of the neurosurgeons. Our office is in Ridgewood. I work almost exclusively at a Valley Hospital. So if you have any questions, there's our contact information with our phone number. You can email me, and then I'll take any other questions that you might have.